This video presents a case review on volume-targeted ventilation, or VTV, in neonatal ventilation. We are reviewing a case of a preterm neonate in the NICU, currently on volume-controlled assist control mode, or VCAC. Let's look at the ventilator screen for a clinical challenge. We need to identify the ventilation mode, understand what the expired tidal volume per kilogram, or VT per kilogram indicates, check if the leak is acceptable, and determine what adjustments should be made. The mode is VCAC with autoflow. The measured tidal volume per kilogram is 8.7 milliliters per kilogram, which is high and indicates a risk of volutrauma, as the recommended target is 4 to 6 milliliters per kilogram. The leak is acceptable at 10%. Volume-targeted ventilation, or VTV, is defined as gas delivery targeted to a preset tidal volume, where inspiratory pressure adjusts breath by breath. This is achieved by the ventilator measuring expired tidal volume and calculating the next breath's pressure. Common platforms include Draeger-Babelog, SLE 5000, and SLE 600. Evidence shows VTV offers significant advantages over pressure-controlled ventilation. It reduces the risk of bronchopulmonary dysplasia, pneumothorax, severe intracranial hemorrhage, periventricular leukomalacia, and hypocarbia. It also reduces the number of days on mechanical ventilation. The primary indication for VTV is preterm babies with respiratory distress syndrome requiring invasive mechanical ventilation. VTV is also beneficial for any preterm neonate on mechanical ventilation, post-surfactant administration, and when weaning from ventilation. It also supports other conditions requiring ventilation, such as transient tachypnea of the newborn and pneumonia. Contraindications for VTV include an endotracheal tube leak greater than 50% or the presence of a tracheoesophageal or bronchopleural fistula, as this compromises volume measurement reliability. Limitations include the need for an appropriately sized ETT and trained staff. VTV is not a substitute for careful clinical monitoring. The general expired tidal volume target is 4 to 6 milliliters per kilogram, adjusted in 0.5 milliliters per kilogram increments. Avoid exceeding 8 milliliters per kilogram to prevent volutrauma, and avoid going below 3.5 milliliters per kilogram to prevent atelectrauma. Key ventilator settings include using VTV with modes like SIMV or assist control, setting peak inspiratory pressure limits, and appropriate PEEP. The ventilator rate should be 50 to 60 BPM for poor respiratory drive and 30 to 40 BPM for good drive. Other settings include inspiratory time and flow trigger sensitivity. In summary, VTV is the standard of care for preterm infants needing invasive ventilation, targeting 4 to 6 milliliters per kilogram expired tidal volume. Monitor the endotracheal tube leak, as VTV is contraindicated if the leak exceeds 50%. The self-adjusting nature of VTV helps reduce BPD, pneumothorax, IVH, and hypocarbia.